Good evening, everyone. Thank you all for attending tonight's event, Concussions Lasting Impact. I'd like to start by acknowledging the Kaurna people, the original custodians of the Adelaide Plains and the land on which the University of Adelaide's campuses at North Terrace, Waite and Roseworthy are built. My name is Olivia Bellis and I'm a PhD candidate in the School of Biomedicine here at the University of Adelaide. It's time to reevaluate how we handle head injuries. Currently, when a person experiences a concussion or a traumatic brain injury, the outcomes vary. While some individuals recover fully, others experience long-lasting impairments that affect their motor function, cognition, and mood. Today, you'll hear about what researchers at the University of Adelaide are doing to forecast patient outcomes with greater accuracy and to spearhead the development of more effective and timely treatments. Tonight's speaker is Associate Professor Lyndsey Collins-Praino. Lyndsey leads the Cognition, Ageing and Neurodegenerative Disease Lab in the School of Biomedicine at the University of Adelaide. She is a 2016 South Australian Tall Poppy and has obtained over $8 million in competitive research funding over the last 5 years alone. Please join me in welcoming Lyndsey to the stage.
Thank you so much, Olivia, and thank you to the organizers of Research Tuesday for having me today, and of course to all of you here and watching online for joining us. Now, how many times are you watching your favorite footy game on the weekend and you see something that looks a bit like this?
Riley Bonner got the smother in and then Simpkin. And the old don't argue and got dumped after he kicked it.
Gets through and this nice and late from Jimmy, just too high, leaves the ground. Our view was blocked here, wasn't it, Joey, because of the crowd, so we didn't see that initially.
This was a match last month in which Jimmy Webster had a hit, quite a high hit, on Jai Simpkins. It resulted in a 7-week ban against Jimmy Webster, and for Jai Simpkins, that was the third concussion that he had experienced in just an 8-month period. While he recovered quite well from it and is said to be doing fine, it does raise questions about what that might mean for what's actually occurring in his brain. So what is a concussion? Well, first of all, it's certainly not something that just affects footy players. A concussion can happen to anyone at any time. It's associated with a type of mild brain injury. And notice that I've put that in quotes because that doesn't indicate that it's unimportant or not serious, simply that it's not typically associated with death. But it can have long-lasting consequences because an individual's brain is suddenly shaken or jolted within their skull. Clinically, it's defined as a score on the Glasgow Coma Scale of 13 to 15, which is within normal limits, loss of consciousness of less than half an hour, and post-traumatic amnesia, which is loss of memory for the events around a concussion, of less than a 24-hour period. But while we do have a clinical definition, it can actually be quite tricky to diagnose a concussion in practice. And the reason for that is because there isn't a single diagnostic test that can tell you that someone's had a concussion. Oftentimes, people won't have conventional neuroimaging like CT or MRI unless it's feared that there may be bleeding occurring in the brain. And even for those who do, it may look completely normal on neuroimaging. And symptoms can vary from person to person, so no two concussions look exactly the same. So what are some of the symptoms that people may commonly experience when they have a concussion? People will report headaches, dizziness or loss of sense of balance, nausea or vomiting, light and or noise sensitivity, confusion, memory problems, or difficulty with thinking. Sometimes people will describe this as feeling as if they're in a fog, sleepiness or excessive fatigue, blurred vision, ringing in the ears, and even mood changes like irritability, anxiety, and depression. An individual doesn't need to experience all of these symptoms to have a concussion, and in fact, many people who experience a concussion may only display a select few of them. Worldwide, there are 69 million traumatic brain injuries each and every year. And of those, over 75% of them are actually concussions or more mild injuries. And estimates have suggested that this may actually be as high as 90% of all traumatic brain injuries. This is particularly concerning because we know that 5 in 10 concussions go unreported and untreated, which is particularly significant when you consider that 10% of contact sports athletes will experience a concussion within any given season. And while concussion very much used to be thought of as a one-off event, with people told to kind of shake it off and get back out there, we now know that between 20 and 50% of people actually report effects beyond the 1-month period. And for some of these can be quite significant and persistent. And that's one of the things we'll be talking about tonight. So, one thing that I want to stress at the beginning, though, is that for the vast majority of individuals who experience a concussion, particularly a single concussion, they actually will recover quite well and have quite good prognosis after injury. You can see that in these graphs here. If you look at the graph on the left, you can see that between 1 and 4 weeks, there's a reduction in the number of symptoms that someone experiences. And in the graph on the right, the likelihood that someone will recover fully and become asymptomatic also increases over time. Now, the gray line here represents females, and the black line represents males. So you can see that there are some biological sex differences between this. Women in general do experience more symptoms following concussion, more persistent symptoms, and show slightly worse recovery. But scientists are really still trying to understand why that might be and what factors might contribute. However, while in general recovery is quite good, it certainly isn't the case for everyone. This study looked at people who had presented at a level 1 trauma center in the US with either a traumatic brain injury or an orthopedic control, something like a broken bone or another type of orthopedic trauma that does not involve head injury. They followed those individuals for 1 year following their injury. And what you can see here is that as time passes on the horizontal line, those who've had a concussion, represented by the black line, continue to have more symptoms than the orthopedic controls, even at that 1 year period. And this hasn't just been reported in this one study. It's been reported in many studies. Here's an example of a study from the UK, following people who've experienced a concussion out to 2 years post-injury. Now, in all of these graphs, the dotted line represents controls, people who've had an orthopedic injury other than the head injury. And you can see that even out at the 2-year period, when we look at things like neurological outcomes, the number of post-concussion symptoms, their quality of life, people who've experienced a concussion are still reporting significant impairments compared to controls. And when we look at things like measures of psychological distress, depression, and harmful drinking, they actually don't show much improvement over the 2-year period and are elevated compared to our dotted control line again. This tells us that for at least a subset of individuals, impairment can persist for several years. And it's important to note that very few clinical studies have actually looked beyond this point of time. So we don't actually really know what happens beyond the 2-year period. Now tuck that away, because that'll become relevant later. And it's not just the clinical symptoms alone. We know that these clinical symptoms and these effects on quality of life can also be associated with underlying brain changes. So, for example, if we look at a structure deep within the brain called the thalamus, highlighted in purple here, we know that this is a really important relay station for the brain. It helps information to get to the brain, and it helps information to get from the brain. And what we see is that in a study looking at people who'd experienced a concussion, they found that at 6 months post-injury, almost half of their sample still had persistent impairments in cognitive function, mood, etc. And if we take a look at this graph here, I want to point out what the different colors mean. The red line are healthy controls, people who've never experienced a head injury. The gray are people who have experienced a concussion but have no persistent impairment at 6 months. And the people in blue are people who've experienced a concussion and do have persistent impairment at 6 months. what we can find is that across many different areas of this deep structure called the thalamus, you see increases in activity in that thalamus, and also you see increases in connectivity with structures that that thalamus connects with. And this is significant because you may be thinking, well, isn't more activity a good thing? Not when it comes to your brain. Your brain needs to keep itself in balance. And so just like a reduction in activity can be a bad thing, so too can an abnormal increase. And that's what we're seeing here, where this level of increase is actually predictive of the number of persistent symptoms that someone shows, suggesting that changes in the brain can be long-lasting, but quite subtle after injury. Now, if these sorts of impairments persist for more than a 3-month period, these are called persistent post-concussive symptoms, or PPCS for short. Some of you may have heard this termed post-concussive syndrome, or PCS, but this term is quite controversial in the field, and it's lost a lot of faith with researchers because it's very difficult to actually class people according to its criteria. So we tend to use the term PPCS more commonly now, and that's how I'll continue to refer to it throughout this talk. So what types of impairments can persist? What might someone who's experiencing PPCS show? Well, it may not surprise you to know that just like a concussion can be quite variable, so too can the persistent symptoms that we see after it. So an individual may experience mood changes like depression, anxiety, or increased irritability. They may be sensitive to light and sound, experience blurred or double vision, or ringing in their ears. They may have impairments in memory, concentration, and cognitive function. Sometimes people with PPCS will use the term, "It's just difficult for me to think. Things just aren't as clear anymore." Headache, dizziness, fatigue, and a variety of different sleep problems that can range from people who are sleeping more often to people who are having trouble falling asleep. And we know that these symptoms can also persist long-term. So this is a study from 2018 looking at all the different symptoms that people report in PPCS. What I want you to notice about this is that they're ranged from most frequent, things like fatigue, headaches, taking longer to think, and having poor memory and concentration, all the way to the ones that are less common, like blurred vision, depression, nausea, and double vision. And what you might notice is that 2 weeks is represented by the darkest blue. And while that's certainly the largest percentage of people endorsing those symptoms, even at 12 months, which is this lighter blue, there still are a significant number of people who are experiencing a very wide range of different symptoms. And this can make it really tricky to actually identify clinically because no two people look exactly the same. And you can get an overlap between these symptoms and many other common disorders. One type of function that's been incredibly poorly studied following injury is long-term motor outcomes. And this work was done by my PhD student, Dr. Lyndsey, who we can now say doctor. She had her PhD confirmed last week. And what she did is she started with 24,000 studies from the literature. I can tell you, I was not her favorite person. She looked at each and every one of them, and she actually found 97 studies that had looked either preclinically beyond 1 month post-injury, or in clinical populations beyond 1 year post-injury. And what she found was quite mixed results in terms of whether or not there are persistent motor impairments. She found that in general, more persistent impairment was accompanied by more severe injury. In other words, people who had had a more moderate severe injury, like you might experience in a car accident, were more likely to have persistent motor impairment than people who had experienced a more mild injury, like a concussion. But she did find evidence of fine motor deficits in people with a history of repeated concussion, which many contact sports athletes might experience. However, there were some significant gaps in the existing literature. Some of these included the fact that the tests that were used both preclinically and clinically differed widely between studies in terms of the way that they measured motor function. They assessed different facets of motor function, and they used different tests even within a single measure, like balance, for example. This makes it really difficult to actually compare results between studies. The other thing that we found was that to date, only 6 studies ever performed in the clinical literature have looked beyond 10 years post-injury. And this is a big gap because we know that traumatic brain injury, including concussion, can set the stage for neurodegenerative motor disorders like Parkinson's. And we'll talk a little bit more about that later tonight. But currently, we have no idea what might happen to individuals in the intervening years. So this is something that we're working hard at in our lab now to try to fill those gaps. In addition to knowing that impairments persist, we need to know the sort of factors that might determine whether or not someone will experience this. So, for example, if you have person A and person B, and they've both experienced a concussion, how do you know what their outcomes will be? Well, the literature tells us that certain factors, like female biological sex, or being older at time of injury, or having had a premorbid mental health disorder like depression or anxiety, can increase the risk that someone will experience persistent impairments after a concussion. Other things that play into this are things like how severe their injury was or how many previous injuries they've had. So that raises the interesting question. Clinicians are pretty bright people, right? How good are they at predicting outcomes for an individual after a concussion? Well, a 2019 study by Corley and colleagues asked this very question. What they did is they asked a panel of clinicians, here are a sample of people who've experienced a concussion. How many do you think are going to recover fully? And the clinicians looked at all of the medical records, they looked at the participants, and they said over 90% of people in this sample will recover fully from their concussion. What happened in reality? Almost half of the sample had persistent functional or symptom recovery deficits at that 3-month period post-injury. This means that the diagnostic accuracy was only 48.4%. They also asked the clinicians to rate how confident they were, and even clinicians who said, I got this, I am extremely confident, were really not much better at predicting outcomes. Now, this is a major issue because currently, predicting someone's outcome after a concussion looks a little bit like this. It's a black box with a question mark. And this is important because it means that many people who experience a concussion aren't adequately assessed and cared for beyond that acute time period. We need better ways to predict outcomes following concussion. And spoiler alert, this is where my research is going to come in tonight, because knowing who's at risk for persistent impairment will help us for better discharge plans from hospital or EDs and specialist referrals. It will help us to provide patients with education about their expected outcomes and what they might actually expect. It will help us to get them to engage with potentially beneficial strategies like rehab or cognitive behavioral therapy. It will allow for enhanced monitoring and follow-up for those who are at the highest increased risk after an injury. And it will allow for earlier identification for therapeutic trials and interventions. What we do know for sure is that traumatic brain injury is not a one-hit wonder. It is an ongoing process in the brain. While you have the initial injury to the brain, which is associated with that jolting or shaking that I mentioned before, it causes a whole host of cellular processes. These can be very wide-ranging, but they're termed the secondary injury cascade. And they include players like increases in oxidative stress, changes in the way that your brain cells can actually communicate with one another, loss of balance of key signaling molecules in your brain, and importantly, increases in neuroinflammation. Because just like you have an immune system that drives an inflammatory response in your body, you have an immune an immune-like system that drives an inflammatory response in your brain. And this is significant because what all of those different cellular processes have in common is that they're very bad for the normal function of your brain cells and can in fact drive increased death of those neurons. And this can increase the risk for neurodegenerative diseases like dementia or Parkinson's disease. Now again, I want to preface this by saying that neurodegenerative disease is certainly not a certain outcome for people following a concussion or traumatic brain injury. The vast majority of people who have a concussion or traumatic brain injury will not develop those outcomes. But we know that a subset will. And so it's really important that we study this to understand who those people are and how we can help them earlier. So, we know that traumatic brain injury increases the risk for neurodegenerative disease in a severity-dependent manner. You can see here, the red line is a more moderate or severe injury, and the blue line is a more mild injury. The more severe the injury, the greater the risk of developing a neurodegenerative disease as an individual ages. But even people with a history of mild injury like concussion still have a significantly elevated risk. And while we're not exactly sure why this might be, we think that it's because traumatic brain injury may actually reduce the threshold needed for a person to reach a neurodegenerative disease diagnosis. What do I mean by that? Well, this black line here is normal aging. And notice that the person never gets to the clinical threshold for diseases like Alzheimer's disease or other forms of dementia. But with traumatic brain injury, it lowers that threshold. It means that they can reach that threshold faster. And the reason for that, we think, is because traumatic brain injury may accelerate brain aging. If you look at the brain of someone who's experienced a traumatic brain injury compared to someone without such a history, it looks older in terms of imaging. And estimates have suggested that this may, on average, be by about 4 to 5 years older. Now, one such neurodegenerative disease that you may have heard a lot about in the media is something called chronic traumatic encephalopathy, or CTE for short. What is CTE? Well, CTE is not associated with a single one-off concussion. It's associated with a pattern of repeated concussions over time. And this leads to a protein called tau to get what's called hyperphosphorylated, meaning that a bunch of phosphate groups get added to it, and it gets sticky, and it starts to clump up, and it does so around the blood vessels of our brain, and it changes the way that the brain can actually communicate. And this eventually will drive the death of brain cells. Now, this does not occur immediately after an injury. It takes years to decades following that pattern of repeated injury. And symptoms appear gradually and then progress over time. They can vary quite a lot from individual to individual, but it's thought to occur in roughly 2 phases. An earlier phase, often in someone's 20s or 30s, which can be associated with things like some mild short-term memory problems, some headaches, depression, insomnia, perhaps a bit of mood change. And then a more advanced and progressed stage, often as someone moves into their 50s or 60s and beyond. And this can include things like motor impairment, like loss of balance and coordination and uncontrollable muscle movements, more significant cognitive dysfunction, and in some individuals, aggressive behavior or even suicidal ideation. Currently, the only way that we can know whether or not someone has CTE is to look at their brain upon autopsy. But researchers are working really hard in order to try to find markers that can be used in living individuals to actually predict their CTE risk. And here in Australia, we're really lucky to have an Australian CTE brain bank where people who are suspected of having CTE can actually donate their brains to be studied by scientists to try to find those markers. And this will also help to understand what determines risk, because research is what drives the answers to those questions. When we look at CTE in the brain, evidence of CTE has been found in the brains of American footballers, which is what we hear a lot about in the media, but also participation in any sports involving a history of repeated contact and collision that can lead to concussion. For example, cases of CTE have been reported in competitive cyclists, equestrian riders, ice hockey players, rugby players, soccer players, martial artists, boxers, UFC fighters, variety of sports well beyond football alone. There have also been reported cases of CTE in military veterans, particularly those who have a history of blast injury. In people who've experienced family or domestic violence, where they may have experienced multiple repeated concussions. And in people who have either occupations or hobbies that are associated with frequent falls, where they're continually having concussions as part of that. And while this was once thought to be something that only showed with advanced age, in August of last year, there was a study that came out that actually looked at the brains of people who had died age 30 or under, so quite young adults, either that had no history of contact sports, and those are the brains on the bottom here, or those who had a history of contact sports, these brains here. And even at this very early age, in these individuals, there were already noticeable impairments. Now again, I want to emphasize that not everyone who plays sports will have this outcome. And in fact, there are many benefits associated with playing sports. So in fact, if you look at American football players, they actually have a lower risk of suicide and score better on many mood measures, which is thought to be due to the benefits of playing sports and engaging in physical activity. So we don't want to discourage people from playing sports. We just want to make sure that people can play more safely, because we need to prevent the sort of repeated concussions that lead to brains that look like that, particularly in young adults. And while there's much that we're still learning about CTE, one neurodegenerative disease that we actually know quite a lot about its link with brain injury is Parkinson's disease. We've known about a link between Parkinson's disease and traumatic brain injury since 1817, when Sir James Parkinson first described the disease. We know that about a third of people who have Parkinson's disease have a history of traumatic brain injury with loss of consciousness. And Crane and colleagues looked in 3 very large studies of aging and found that across all 3 studies, when you looked at people who had a brain injury with a loss of consciousness of more than 1 hour, it was associated with an increased number of cases of Parkinson's, as well as faster progression of the disease, though the way they measured that was a little problematic. A really convincing study by Gardner and colleagues here in US military veterans found that people who had experienced a mild traumatic brain injury, which is this blue line here, had a 56% increase in risk of developing Parkinson's. And when you looked at more severe injury, represented by this orange line, that actually increased to 83%. So while Parkinson's disease is still a rare outcome and certainly doesn't affect everyone with a history of concussion or TBI, we do know that it is a significant risk factor in a number of cases of Parkinson's that we see. So Angus McNamara, another PhD student in my group, actually asked the question of whether or not in someone who has established Parkinson's disease, traumatic brain injury can change the progression of it. And he essentially worked in a database called the Parkinson's Progression Markers Initiative, or PPMI, which is both the blessing and bane of our existence. It's the largest worldwide database to actually look at people with Parkinson's. And he was able to divide into a group of people with Parkinson's with no history of head injury, those with a history of concussion, and those with more severe injuries, and found that these groups were not different from each other in terms of their age or their biological sex distribution or their years of education. He then did a very comprehensive panel of analysis where he looked at things like neuroimaging, various biomarkers in the blood and cerebral spinal fluid that we know play a role in Parkinson's, cognitive function, mood function, and motor function, and didn't see a difference on any measure in terms of established Parkinson's disease progression. These graphs here just show a couple of examples of different biomarkers. This is dopamine binding in the brain, and this is a protein called alpha-synuclein. And what you might notice is that none of the colored lines really look very different from one another as progression happens over time. So it may indeed be that in established disease, once the disease process kicks off, traumatic brain injury doesn't play a role in driving the progression of it, but we need to do more analysis to really be able to look at this in a more selected population. PPMI wasn't designed to look at brain injury. However, while we still can't definitively answer a question about progression, we do know that Parkinson's disease represents an exciting opportunity. And the reason for that is because the dotted line here is when somebody typically is diagnosed with Parkinson's currently. And from there, they have the normal course of the disease that we think of when we think of Parkinson's, the motor impairment, the cognitive impairment. But when we reach this dotted line, people have already lost 60% of a chemical in their brain called dopamine, which changes the way that their motor function and their decision-making and a variety of things like motivation and effort-related function actually work. And so what we know is that prior to the time that we reach that catastrophic loss, there's a whole host of changes that are happening in the brain for decades prior. And these are associated with symptoms like loss of sense of smell, things like REM sleep behavior disorder, constipation, depression, a variety of different symptoms, which you may look at and go, isn't that just part of getting older? Not when it occurs to the extent that they do in combination together. We need to get better at recognizing potential constellation of symptoms, which are not just part of normal aging. And this reason that I say that Parkinson's presents an exciting opportunity is because since we know that traumatic brain injury is a risk factor for Parkinson's, we can actually track people with TBI over time to help predict factors that drive those impairments and that help to predict the risk of conversion to PD long before they ever reach the dotted line. So another PhD student in my lab, Samantha Edwards, is actually doing this preclinically and doing a really comprehensive assessment of motor outcomes following traumatic brain injury. And she's not just looking at the effect of TBI alone, she's looking at what happens when you combine it with other known risk factors like pesticide exposure, because none of us exist in a vacuum. If you've experienced a concussion, there's also a greater likelihood that you may have had a virus at some point in your life, that you may have been exposed to pesticides at some point in your life, that you may have had an occupation in which you were exposed to certain industrial solvents. And throughout the course of your life, all of these individual risk factors may add up and act together in order to drive that conversion. So there's an effect of injury on both things like balance, motor coordination, and limb movement. And this was at a 3-month post-injury time point. We're currently assessing longer time points because, as I said before, there's a really significant gap currently in understanding how motor function evolves over time following injury, and also looking at how that may interact with pesticide exposure, whether or not that may worsen the profile. So this raises the interesting question of what sort of factors drive elevated risk of PD following TBI. And first we need to understand a little bit about the pathology of PD. So if you look deep within your brain, if you could imagine cutting a sort of right down the center of it, you would find in the middle of your brain a structure called the midbrain. I always love how anatomists made that easy for us. So the midbrain, right in the middle of the brain. And what you notice is that there's this quite dark structure in it in someone who does not have Parkinson's disease. This is called the substantia nigra. It literally translates to black substance. These are the neurons that contain that chemical dopamine that I mentioned before that helps with normal movement, that helps with motivation, that helps with decision-making, and a variety of other functions. Those neurons have a pigment called neuromelanin in it. And just like melanin gives color to your skin, neuromelanin gives that color to those dopamine neurons. In Parkinson's disease, because those dopamine neurons are lost, so too is the pigment neuromelanin. And so notice that in someone with Parkinson's disease, the neuromelanin looks quite washed out. The substantia nigra looks quite washed out because of atrophy. And the consequence of this is that substantia nigra sends its dopamine to the cortex, the wrinkly part of your brain, particularly to these orange regions here, which together are called the striatum. So what ends up happening is that you lose dopamine input to the striatum, and that then results in the sort of motor symptoms and also plays a role in the cognitive symptoms that we see in Parkinson's disease. Now, interestingly, in our preclinical model of traumatic brain injury, at 12 months post-injury, we actually saw increases in dopamine D1 receptors in the prefrontal cortex, the part of your brain right behind your forehead, and that was following mild injury specifically, concussion in other words. And this was really interesting because we also saw significantly increased anxiety following injury, of mild injury. And so while it may seem counterintuitive, and you might be thinking, well, you just told me dopamine's lost, so how could you see an increase in dopamine receptors? Well, receptors are like the locks, and dopamine's like the key. So sometimes if there are fewer keys, in order to increase the likelihood that the remaining keys will find a lock, the receptors upregulate and you get more of them. So this increase may actually be pathological and may be the brain trying to compensate for changes in dopamine. We're still assessing that in greater detail. But dopamine doesn't act alone. We also know that another major player is alpha-synuclein. What is alpha-synuclein? Well, alpha-synuclein is a protein that helps your brain cells to communicate with one another. And in Parkinson's disease, for reasons that we don't quite understand, it starts to clump up until it forms these big aggregates called Lewy bodies, which sit there in your brain cells and can actually cause those brain cells to die. But what's also quite concerning is that this alpha-synuclein, this misfolded alpha-synuclein, can actually be transmitted from diseased brain cells to healthy brain cells. And in this way, the pathology of Parkinson's can actually spread throughout the brain. And that spread actually follows the progression of symptoms, from more loss of sense of smell and some of those constipation and other autonomic dysfunction that I talked about when we talked about the early symptoms before diagnosis, to the motor symptoms that we see in later stages of the disease and the sleep disorders, all the way out to the cognitive and mood dysfunction that we see later on. Now, people have looked at alpha-synuclein following traumatic brain injury and found that in several different models, it's actually significantly upregulated following injury, at least to about 8 weeks following injury preclinically. And this is also supported by what's seen in the clinical data, where in both acute and pediatric survivors of a more severe traumatic brain injury, there was a 5 to 10-fold increase in alpha-synuclein levels in the cerebral spinal fluid. And this has also been found on autopsy studies, where alpha-synuclein has been found in the long cables that carry messages in your brain called axons. And this is really significant because that's one of the earliest pathological changes that we see in PD. So alpha-synuclein changes persisting after injury could perhaps help to drive this risk. However, it's science and nothing is ever so straightforward. It appears from at least our preclinical data that these increases may be transient. We looked in both the substantia nigra, which is the place where those dopamine neurons reside that start to die away, and in the part of the brain that receives that dopamine, the striatum, and we didn't see any changes in alpha-synuclein at the 12-month time point after injury following any severity of injury. This has been found in other preclinical models where it seems like these levels return to normal about 16 weeks post-injury. And it's also been found in older military veterans with a history of TBI compared to those without, where there weren't any long-term changes in alpha-synuclein. So the jury's still out a little bit in terms of whether or not alpha-synuclein is what's driving that risk. And one more biological mechanism to talk about is inflammation. We know that following traumatic brain injury, there's a massive upregulation of inflammation within the brain as your brain reacts to the injury itself. Now, interestingly, in Parkinson's disease, neuroinflammation has been proposed to be what's driving the death of those dopamine neurons. We know that the substantia nigra is really, really sensitive to inflammation, and particularly those dopamine neurons. And we see evidence of cells called microglia, which are your brain's major immune cell, upregulated in the brains of people with Parkinson's. But what's really interesting is that the inflammation following traumatic brain injury never seems to quite settle back down to baseline levels. This has been shown at autopsy, where even at time of death, people who experienced a brain injury decades prior still had significant elevation of those cells, those microglia. And this has even been demonstrated in living brains using a PET tracer, where activation of those cells has been found up to 17 years following injury. We've looked at this up to 3 months post-injury following both moderate and severe TBI, as well as repetitive mild TBI, and we didn't really see any changes after a more severe injury, but we did see upregulation following those repeated injuries over time. So it may be that you need to have that repetition of injury to drive those changes in inflammation long-term, something that we're still investigating. And we have looked, however, out to 12 months, and we saw just really some very mild evidence of microglial activation at that time, and it was mostly after more severe injury. So still some questions that remain there as well. So, given how many questions remain, it may be that we need to be studying this risk in large clinical populations. So I'd like to end the talk tonight by introducing you to our study, which we call FINE TBI affectionately. The reason we do that is because FINE TBI stands for Forecasting Risk of Long-Term Impairment and Neurodegenerative Disease Following TBI, and we don't want to spend half our meetings saying that, so we just say FINE TBI. It's a hypothesis-driven approach saying that an individual who experiences a TBI has chronic neuroinflammation that persists in their brain, that drives the death of those vulnerable brainstem neurons in areas like substantia nigra, that this drives persistent cognitive and motor impairments, and eventually leads to the emergence of neurodegenerative disease, like Parkinson's. So here in South Australia, we are in the process of recruiting 800 individuals from our community, 100 healthy controls, 100 individuals with established diagnoses of idiopathic PD or Parkinson's disease by a neurologist, and 600 individuals who've ever experienced a brain injury of any severity. This can range from more mild TBI, like concussion, all the way to more moderate severe injury. And we're looking at people who are within 1 year post-injury, within 10 years post-injury, and beyond 10 years post-injury. Because for each of the steps in that hypothesis that I mentioned, we are investigating it quite objectively. In order to look at TBI, we have a questionnaire asking you about what was your injury like and the different characteristics, and wherever possible, we medically confirm that. We're looking at sensitive blood-based biomarkers for neuroinflammation, and we're also the first group in the world to use a novel PET tracer to look at neuroinflammation in the living brain of TBI survivors. We're doing world-class imaging to look deep inside the brain at those structures like substantia nigra that sit deep down where conventional imaging isn't really good at seeing. And we're working with experts in imaging who are looking at changes in those structures that haven't been seen before, potentially. We're not relying on gross clinical measures. We're actually developing in-house cognitive and motor measures that actually are depend on the function of these deep structures in the brain so that we can see subtle impairments. We're not expecting that someone who's experienced concussion may still be showing gross impairments at 10 years post-injury, but there may be subtle changes happening that are being missed by some of these big scales that are used in other studies. And finally, we're looking at sensitive blood-based biomarkers related to neurodegeneration and also comparing against people who we know have Parkinson's disease to look at how the brains of survivors of TBI of different severities and time points post-injury may compare. So what do we do with all that data? Well, we feed it to something far smarter than any of us will ever be, We're harnessing the power of machine learning in order to try to improve diagnosis and prognosis. So we take all of our data and we essentially feed it into a computer so that the computer can learn what the brain of someone with traumatic brain injury looks like, what different severities of injury, what different time points post-injury, compared to either people without such a history or people with PD. And while we're only comparing cross-sectional, so between groups at the moment, the hope is that once we establish the cohorts, we can follow them over time. And this will allow us to actually, hopefully, generate algorithms that can help to predict risk of long-term impairment and neurodegenerative disease, so that people who've experienced a concussion or brain injury no longer know what it's like to sit there and see nothing but a black box and a question mark sitting in front of them. Because the future of medicine is personal. It is not a one-size-fits-all approach. Currently, it is true that long-term prognosis after injury is unknown. As I've said, about 20 to 50% of people will still experience impairment even beyond that typical recovery period. And we know that a subset of those will continue to have persistent impairment for a long time. In one study, about 25% of the sample continued to show worsening between 7 and 14-year follow-ups. But by understanding the brain mechanisms that may underlie risk, we can achieve earlier identification and hopefully more effective therapeutic interventions. Because once your brain cells are lost, we can't put them back. But if we know you're at risk, we may be able to stop them from being lost in the first place. And so we hope to provide clinicians with the tools that they need to remove the black box and inform individuals about their prognosis. So if you'd like to get involved, or you know someone who's experienced a concussion or traumatic brain injury, scan our QR code, visit our website, or email us at find_TBI@adelaide.edu.au. There's also a number of members of the research team who'd be happy to chat with you about what it involves afterwards. And if you're curious about what you can do to reduce your risk, follow your sports guidelines and protocols to reduce risk, particularly of repeated concussions. There's a lot of changes in terms of AFL return to play guidelines that are coming out, soccer ball heading guidelines, particularly in the US and UK, that can help to make it safer to play the sports that we love. We can take action to avoid falls, like not standing on unstable surfaces, making sure that you do things like secure area rugs and light cords. I tell my mother this all the time. She has a light cord that is just a death trap waiting to happen. Learn from my mother's mistake. Please secure your light cord. Fasten your seatbelt and use appropriate child safety restraints. No child under the age of 7 should ever ride in a front seat. Reduce that risk of concussion. Enforce rules that penalize rough play or excessive contact in contact sports at all levels, from youth sport all the way up to the pros. Follow current best practice guidelines for gradual return to play or work after an injury. And engage in exercise and mental activity after an initial rest period if you have experienced a concussion. It's really important that you keep your brain and your body moving once your clinician tells you that it's safe to do so. And if you have experienced a concussion or TBI and you need support or information, there's a number of resources here in Adelaide that you can get in touch with who can provide you with more education and contacts should you need them. The Orange Butterfly, Connectivity, and Brain Injury Australia, and you can contact Research Tuesdays in order to access those resources. So no man is an island, no research happens in a vacuum. I'd like to thank everyone behind this, including the Candle Lab, Associate Professor Frances Corrigan, who has taught me everything that I know about concussion and TBI. I was very much a Parkinson's and dementia girl when I got to Adelaide, and she really expanded my horizons. The FINE TBI team and collaborators, particularly Dr. Irina Beitu, Professor Mark Jenkinson, Britt Burton, Angus McNamara, Ben Ellel, Brittany Child, the whole crew are amazing RAs who keep it all functioning day to day, and our funding and community partners. And there's the QR code if you didn't have a chance. So here at the University of Adelaide, we're making history, and we hope you'll be involved.
Thank you, Lyndsey. We'll open it up to questions from the audience, and for those online, please submit via the Q&A section of the webinar. But I'll kick it off with some pre-submitted questions. So we've got, what are the best ways athletes can protect themselves from the risk of concussion, especially when it comes to children and AFL players?
Yeah, that's a great question. So I think traditionally people have talked about helmets, but actually it's a bit of a myth because current helmets do not protect your brain sufficiently from the rotational forces and impact that can occur. And so we have to be, and actually there's some studies suggesting that the sense of security that athletes can feel when wearing a helmet can cause them to engage in actually riskier behaviors. Now there is some evidence for mouth guards, and that's something that's being investigated more. In fact, there's some researchers here at the University of Adelaide who are looking at that, not just for concussion, but for all the little subconcussive impacts that can happen as well. But there's more validation of that sort of work needed. It's really a field in its infancy. I think that one of the best ways that people can protect themselves is to follow current best practice guidelines. So the sporting groups here in Australia in particular, I can speak to more personally, they're working really hard to work in conjunction with researchers and to learn from the research and to modify the guidelines accordingly. So for example, just last month, the AFL decided that they would maintain their 12-day return to play guidelines, but they have a 3-phase, 11-step heavy monitoring period after their concussion. What they did do, however, was for other levels of play, all play levels below that, it was instituted that now it'll be 21 days before return to play, which is a little bit longer. So that's changing. In the US and UK, they've outlawed soccer ball heading in children under the age of 12. That hasn't yet come to Australia. One of the reasons for that is because some researchers in Australia have said that heading the soccer ball is actually a really important skill for soccer players who are going to go on, and I guess about 25% of goals are scored that way in competitive international play, and so it's really important people learn to have that skill safely. So I think that the big mantra is don't rely on a helmet to keep you safe. Instead, really focus on those guidelines, really focus on playing safely, no high contact, no ground contact with the head wherever possible. Yeah.
Okay, thank you, Lyndsey. So we'll open it up to the audience. Did anyone have a question? Yep. We'll just get somebody to, come give you the mic.
Thank you. Yes, interested in your comments about the gender difference, male to female, and the severity of concussion. Mm-hmm. Certainly we know that female skulls are thinner than male skulls, mm-hmm. and I wonder if that's a factor. And having worked in Darwin some years ago and seen a lot of trauma, mm-hmm. and in full-blood Aboriginals have extremely thick skulls. Mm. So I wonder if there's some ethnic differences. But of course, you need to compare the force of impact to make sense out of those sort of differences.
Yes, I think some really good points there. So in terms of the sex difference we see between males and females, it's not really clear what's driving that. So people have thought that perhaps it is due to smaller body size and thinner skulls in females, that perhaps the impact that they experience is a harder impact to the brain. Other people have suggested, however, that hormones may play a role in it. And we know that there are differences, for example, in the immune system of males and females that may also play a role. And that's also been hypothesized to play a role in some of the disparity that we see in dementia rates between females and males as well, where we see a similar pattern, at least when it comes to Alzheimer's disease. So I think that there are so many individual components just biologically that can contribute to those sex-related differences. And then you start to add in all of the different injury differences as well, differences in severity of impact, where people are striking the head, whether it's a penetrating injury or whether it's a more diffuse injury, what was the rotational force. It's something that can make it quite tricky to study. And I hope that more biomechanical engineers kind of get interested in the question, because I think they can help us to answer some of those questions.
Yep, we've just got one up there.
Hi, I'm just wondering if you've established any possible link between TBIs in young people and them developing diagnosable personality disorders like ADHD or any of, say, some autistic type symptoms?
So there has been quite a bit of literature looking at mental disorders after traumatic brain injury. We know that irritability, depression, anxiety can all be increased. You can see increased incidence of PTSD. You can see increased incidence of ADHD-like symptoms. I can't comment particularly on things like autism. I don't know that literature as well, but certainly several other mental disorders have been linked to having an increased prevalence after TBI, but it can be a little bit of a self-selecting literature, because we know that people who experience persistent impairments are also more likely to have pre-existing mental health diagnoses. And so it can be difficult to actually kind of tease apart the causative pathway there. And I think also we have to be really careful when we talk about some of the persistent risks of concussion, because it can be iatrogenic in and of itself, which essentially means that if you scare people into thinking, oh my gosh, I've had a concussion, all these horrible things are going to happen to me, then they may, it may be almost a self-fulfilling prophecy where they then become really scared and they overly focus on it and become very anxious about it and very depressed about experiencing the injury. And another PhD student in my lab, Benjamin Ello, who's here tonight as well, is looking into this. He's conducting a survey internationally right now, looking at healthcare professionals who've treated people with a history of concussion or TBI, and what's their awareness of these persistent risks, how are they educating patients about it, and the theme that he sort of talks a lot about is the idea of raise awareness, not alarm. So it's how do you properly educate people, because we know that there have been a number of studies showing that if you educate people about potential outcomes, they're more proactive in seeking help. They're more aware of resources that might exist. And so there's a number of really positive benefits of that, and they do have better outcomes. But how do you prevent unduly alarming someone about outcomes that really are quite rare? Because again, most people, the majority of people who've had a concussion will recover fully from it.
Just have time for one more quick question.
Sorry, this isn't really a question. My husband had a severe traumatic brain injury in a road accident just over 6 years ago when he was 74. He mashed his frontal lobe, basically. He's lost executive function. His short-term memory is terrible. And I can see him slowly deteriorating. He knows, and in quotation marks, that he is exactly the same as he was pre-injury. Is this a common situation?
Whenever we talk about traumatic brain injuries, particularly those that affect the prefrontal lobe, where a lot of decision-making and judgment and executive functions sit, we need to be a little bit careful about the level of insight that an individual may have into the sort of impairments that they're showing. So what I sometimes say to people is that if it's a consistent message coming from loved ones and from other individuals who know someone, it may be beneficial to just have a conversation with your GP and see if an additional referral, just to have a bit of testing, is warranted. I think that sometimes that can be a really difficult conversation to have, but the earlier that we identify risk, the more we can do about it. That's why I think that education of individuals is so important around these issues.
Thank you.
Great. So we'll wrap up question time now. I'd like to finish now by thanking tonight's inspiring speaker, Lyndsey Collins-Praino.
Thank you.
And thank you to you, our audience, for viewing and for your questions and comments. Be sure to sign up to our mailing list for the latest information about Research Tuesdays and related news. And thank you for tuning in once again, and we hope to see you next time. Good night.